Good morning, respected judges, my senior friends, and my colleagues. Today, my topic is the effect of assisted reproductive technology on IOP and CCT in women undergoing IVF. We do not have any financial disclosure. Introduction. Eye is the target organ for sex hormones, demonstrated by the innumerable number of sex steroid receptor mRNAs seen in a variety of ocular structures. Pregnancy, which is a physiological high hormone state, influences ocular morphology and visual function. In pregnancy, IOP decreases because of the increased outflow due to increased uveoscleral outflow and decreased episcleral venous pressure due to the effect of sex hormones. Artificial reproductive technology addresses infertility. It includes procedures like IVF, ICSI, IUI, and IFT. The first step in ART is ovulation induction, done with a gamut of drugs like OC pills, GnRH analogs like luprolide, letrozole, gonadotropins, estrogens, and progesterones, which are given from day 1 to day 5. An injection HCG is given on day 6 to day 10, and injection HCG is given on day 12. Ovulation is checked on day 14. Administration of sex hormones exogenously as in ART influences ocular morphology and function similar to those in pregnancy. Due to easy accessibility and success rate, albeit more and more women are undergoing ART, so it's important to know the effect of ART on IOP and CCT. The aim of the study is to know the effect of the drugs used in assisted reproductive technology in IOP and CCT in IVF patients. And objectives are to compare the effect of these hormones on IOP and CCT, and they are checked at the time of registration and after the completion of the cycle. Our study is a prospective cohort study and 57 women were included. Baseline ophthalmic examination was done for all patients, and NCT is used for IOP monitoring and OCT is used for CCT monitoring. And our patients with ocular surgeries and prior ocular diseases were excluded from the study. Data was collected and analyzed appropriately, and quantitative data is represented by mean and standard deviation, and qualitative data by frequency and percentage tables. A p-value of 0.05 is taken as significant. These are the general characteristics of the patient. And this is the effect of ART on IOP and IOP. This is the table representing the IOP before treatment and after treatment. This is the graphical representation of IOP after ART, showing a decremental pattern. And this is the graphical representation of effect of ART on CCT, showing an incremental pattern. Coming to discussion, just as pregnancy causes physiological alterations in hormone levels, ART also induces similar changes that are comparable. Hoven and Johans observed a difference in mean IOP between pregnant and non-pregnant women, which is statistically significant. They also stated that IOP decreases in pregnancy due to the effect of hormones. Our study showed a decrement in IOP due to ART. So it is in accordance with the above study. Park et al. Prospectively followed 24 pregnant women and found an increase in corneal curvature. Bengi et al., Guthrie et al., Soni et al. Stated separately that the corneal thickness is more during ovulation due to estrogen peaks. ART drugs, which induce increased estrogen for producing ovulation induction, also had the similar effect on CCT. So this is in accordance with my study. Coming to conclusion, CCT values are significantly higher in women after ART. IOP and CCT should be measured as an integral part of ocular examination in women undergoing ART, and ophthalmologists must be aware of this elevated CCT. Thank you. These are my references.
Thank you, Dr. Lalita. I just had one question. Did the IOP really decrease, or was it a secondary result of increased CCT?
Ma'am, actually we measured this IOP and also checked the CCT. According to CCT levels only we checked again the IOP, ma'am. Because for every 10 microns increase in CTC,
so that means it was stable. Did it really decrease?
Slightly there was decrease, ma'am. So I have written like slight decrease in IOP. And it was statistically significant also.
You have studied, no? What was the amount of decrease? You can't say slight decrease.
Yes, ma'am. Yes, sir.
How much was the decrease?
2 mm of HG it was decreased, so then the standard standard deviation was plus or minus 1, sir.
And then you didn't apply the correction factor for CCT.
Correction factor we applied, sir. For every 10 microns of increase in CCT, the 0.7 mm of Hg was reduced, sir. Was decreased from the IOP, sir.
So IOP reported is corrected or it's uncorrected?
This is the corrected one. This is the corrected one. The one which I represented in the table is the corrected one. After correction.
You mean to say the values which you have presented in the table are the corrected ones?
Corrected
So
one, sir.
you should have presented the original values also before correction so that we can understand. So there confusion would not have been there.
Right.
You would have to present two values, one uncorrected and one corrected.
Right, sir.
Okay. Thank you, sir. Next presenter is Dr. Swati. Can you use other podium also? Is it ready? Yeah, you can go there. And the next presenter should be ready at this podium, Dr. Namrata. Dr. Namrata, you will have to be ready here.
It's not on. It's not on. You want to keep that laptop?
Hello. Hello. Good morning, everyone. Myself, Dr. Swati Chauragade. I am the junior resident from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Varda, Maharashtra. I am here to present my study on clinical presentation of glaucoma based on socio-economic profile. Glaucoma is defined as a multifactorial chronic progressive optic neuropathy caused by a group of ocular conditions causing damage to retinal ganglion cells at levels beyond the normal baseline age-related loss, resulting in the optic disc changes and the corresponding visual field defects, with the raised intraocular pressure being the important modifiable risk factor. After cataract, glaucoma is the second most common cause of blindness worldwide, and it is becoming more common and predicted to afflict the 111.8 million individuals worldwide by 2040. The aim of the study was to evaluate the clinical and the social profile of glaucomas in a tertiary care rural hospital, and the objectives were to determine the clinical types of glaucomas among the patients presenting to glaucoma clinic and to document a socio-demographic profile of the study population. And all the consecutive glaucoma patients presenting to glaucoma clinic were studied, excluding the childhood glaucoma and the ocular hypertension. It was a hospital-based analytical study where the 70 consecutive glaucoma patients were studied over a period of 6 months. And the suspected glaucoma cases were further worked up, for which included the Goldman applanation tonometry, gonioscopy, assessment of angle of anterior chamber, OCT and perimetry were done wherever feasible. And all these patients were then categorized based on the socioeconomic status scale updated for 2019. And the scale included the scores for the education of the head of the family, occupation of the head of the family, and monthly family income. And the scores were calculated and categorized. And this was the proforma used where the clinical risk factors like the age, the sex, systemic hypertension, diabetes mellitus, and the history of any ocular trauma or ocular surgery, and the refractory errors were asked. And the information regarding the socio-demographic profile like the habitat, if the patient is APL or the below poverty line card holder, or the monthly family income, education of the head of the family, occupation of the head of the family, and total marital status, and the social status was calculated. And the results were out of 70 patients, 55.7% belonging to the lower socioeconomic class presented with the advanced glaucoma, 31.4% belonging to the middle socioeconomic class presented with the moderate glaucoma, and 12.8% belonging to the upper socioeconomic class presented with the mild glaucoma. The glaucoma is the leading cause of irreversible vision loss, and patients with the socioeconomic deprivation tend to present late. Therefore, the screening of all the patients should be done at the village level itself with the dilated fundus evaluation or the digital tonometry or the handheld fundus camera, so that we can prevent it. And the literate people from the village should be given the health education regarding the glaucoma, so the blindness can be prevented. Most of the patients presenting to glaucoma clinic were from the socioeconomic classes, from which the upper presented with the milder form, The middle socioeconomic class showed the moderate glaucoma, and the lower socioeconomic class presented with the advanced glaucoma. And this was the glaucoma information sheet which were given to the village people who are literate, so that they can literate the other, so that they can help the other people also. Thank you so much.
Dr. Swati, who were the glaucoma suspects? You said those who were glaucoma suspects underwent all the tests for the...
Yes, ma'am. Actually, the patients who came to the glaucoma clinic of our tertiary care.
All of them were enrolled?
No, either they are having the optic disc changes, but not having the intraocular pressure rise, or having the intraocular pressure rise, but not showing the optic disc or the visual field defect. So they were further worked up thoroughly, so that we can diagnose them as glaucoma, or or it is something else.
And how was the IOP tested in the field?
Not filled, by with the Goldman appellation tonometry, we calculate, we measure the intraocular pressure, ma'am.
You set up the center there at the village level?
Yes, sir. Actually, we conduct there the camps continuously throughout the year. So we bring the patient from the camp, and we treat them, and then we
Exactly, like when you are talking about screening,
yes, sir.
screening has to be done for everybody. How did you measure the IOP when you are screening for everyone in the village? I'm not asking about the base camp, like you are getting the patient and doing the government is different from
Yes, sir.
screening the population with government. What was your protocol? What was your method?
Sir,
How did you measure the IOP at the screening base?
I think you mentioned digital.
digital tonometry at the level of at the village level, and when we bring the patients to our center.
Digitally as in finger.
Was
So
there
with
any
the
other method available apart from digital tonometry and that applanation tonometry?
Yes,
There
sir.
are methods in between, like portable tonometer.
Sure tonometer, yes,
So
sir.
that would have been little better than digital tonometry, where the
Yes, sir.
screening would have been little.
Better.
Miss, do you know? Just I didn't get that. What was the number of patients? How many patients were screened with digital tonometry, and from that, how many you picked up to be referred to the
Hospital.
base hospital, and then how many of those digitally high suspects did you really measure high Goldman standard pressure? Can you give me the breakup? One center. One day you went to a village. How
Yes.
many people at the village level you did digital tonometry? From suppose you have seen 100. Out of that, have you referred 40 to the base hospital? From those 40 suspected digitally high IOP cases, how many were really high on application?
Actually, sir, we go to the camp village level, and we bring the patient to our center only, and then we actually do this all the test. And if someone has the glaucoma features, then we treat them separately, and the glaucoma.
I get your point, but I just want to know the number. How many from the village?
Yes, sir.
Suppose you have screened 100. Suppose you have referred 40 to the base hospital with suspected digitally high IOP. All those 40, what was the outcome with application? How much was the IOP in those 40? Do you have a breakup? My question is very simple.
Yes, sir.
Digital tonometry is relative. Most of the times, the borderline cases you may not know by digital tonometry. So applanation is the gold standard that is
Yes, sir.
accepted.
Yes, sir.
What I said is handheld pop tonometer like thing. Suppose you would have used in your study,
Yes, sir.
wouldn't it have been a little better step?
Yes, sir.
And what we gather from it is the person who did the digital tonometry is not the person who did the applanation. Okay. Isn't it?
Yes, sir.
Thank you.
No, I have a question, sir.
Sorry.
My question is, how many patients were there in the screening camp total?
So actually, there we arrange camp for cataracts only,
So how many, I want the number.
around 300 to 400, sir.
300 to 400 you examined in a day.
No, sir.
And how many days?
Sir, actually, we bring the patient for cataract surgery only.
You did
and
screening in the village.
yes, sir.
How many patients did you examine in the village?
There was 320 to 350 something.
In how many days? 1 day, 2 day, 3 day?
So 1 day.
1 day can.
Yes, sir.
Out of those, you suspected 70 were glaucoma suspects,
Yes,
right?
sir. Yes, sir.
Of these 70, how many were just based on digital tonometry? Besides, there must be somebody, as you said, this suspect. There must be somebody else who was somebody else. But based on digital tonometry, out of these, how many were 70?
So digital tonometry for around 20 to 30 only, but we
Okay.
suspect.
Okay, 20 to 30 based on, and how many were the cases with glaucoma detected of these 70? Of these 70 suspects, how many were actually detected with glaucoma? You don't have the numbers here. What was the total number of glaucoma patients detected?
Okay, so what is your conclusion of your study in one sentence? What is the take-home message?
Yes, sir. The lower socioeconomic group who are illiterate or who have difficulty to accessibility and the affordability of the healthcare facilities, they actually present in the advanced stage. So which can be prevented by the awareness of the glaucoma also. So because the glaucoma is the irreversible and preventable disease. So
Dr. Swati, don't
yes,
go into that. Why? I'm just not getting the numbers. How many were glaucoma patients? Can you give me? Because your study is based on that.
What he is looking at is considering the prevalence of glaucoma.
Not only
the
prevalence,
incidence
sir.
of-
I
the
want to
incidence
know
of
how many
glaucoma.
of these
Yeah.
patients were glaucoma and how many were actually early and how many were moderate and how many were advanced. Because out of these 70, I want to know how many were total glaucoma patients. Because your sample size is too small. You are breaking it up into 3 groups and early, moderate and advanced. What were actually the numbers you are not giving? You are just giving us the percentages. I want the actual numbers. How many were there out of these 70 with glaucoma? Give me a number. 10, 20, 25. Give me a number.
It's not there.
It's
You've
not there.
analyzed it, no?
It's not there. And then when you break up this into early, moderate, advanced, the numbers will shrink further.
okay.
And they will be so small that based on that you can't do any statistical test. What was the statistical test done? Have you done any statistical evaluation? You are saying a take-home message that lower socio-economic people come with advanced glaucoma. What is the statistical test done to give this message? Do you have any test? Yes or no? You don't have the numbers, you don't have the tests. On what basis are you giving the take-home message?
Swati, the idea is good. You're from an institute which does lot of work, right? So I suggest you go back and again just look at the study
Yes, ma'am.
and I think do a better job.
Yes, ma'am.
Okay.
Methodology and everything.
Yes, ma'am.
Okay.
Thank you.
Thank you.
Thank you.
So you got 2 presentations? Okay. Next to Dr. Namrata, Dr. Nilesh Kumar, is he present? Yeah. Please be there on this podium. So back to back you are presenting two papers. Huh?
If you want, I can back to back or I can do later.
One lecture, then discussion, then other lecture. Then
Yes, yes.
Okay.
You
Okay.
finish both your talks.
Good morning, one and all. Today we are going to discuss a hospital-based study on combination of brinzolamide timolol versus dorzolamide timolol in glaucoma. Glaucoma, a group of disorders characterized by chronic progressive optic neuropathy resulting in a characteristic appearance of optic disc and a specific pattern of visual field effect that are frequently but not invariably associated with raised IOP. Normal IOP ranges from 10 to 21. Ocular hypertension treatment study and collaborative initial glaucoma treatment study shows that 50 to 75% of patients require combination therapy at some stage of the disease and may need 2 or more drugs to achieve target pressure. A fixed combination has various potential advantages: no risk of dust washout, reduced exposure to preservatives with reduced side effects, reduced treatment cost, better patient compliance, and quality of life. Previous studies like Mani et al. And Holo et al. Have found that brinzolamide timolol and dorzolamide timolol have almost similar efficacy at lowering IOP. The purpose of this study was to compare the efficacy of IOP reduction and patient compliance of brinzolamide 1% plus timolol maleate 0.5% fixed combination and dorzolamide 2% plus timolol maleate 0.5% fixed combination in a hospital-based population with primary open-angle glaucoma or normal tension glaucoma. We did a prospective randomized controlled clinical study. 86 eyes of patients with primary open-angle glaucoma or NTG were randomized to receive either brinzolamide timolol or dorzolamide timolol. 43 eyes in brinzolamide group and 43 eyes in dorzolamide group. Male or female of 18 years, above 18 years of age are included, who were clinically diagnosed of POAG or NTG, who were uncontrolled on a single or a double medication other than the eye drops we studied. Exclusion criteria were active ocular disease other than glaucoma that would interfere with study outcomes, sensitivity or allergy to any component of either study drug, pregnancy, planning a pregnancy or breastfeeding, functionally marked visual field loss, ocular surgery within last 3 months, concomitant uses of ocular drugs except intermittent use of artificial tears, active systemic disease or plans to change ongoing systemic treatment that might affect IOP. Diabetic retinopathy were excluded. IOPs were measured at baseline 2 weeks, 1, 2, and 3 months. Main outcome were measured the mean change in IOP from baseline at every visit. Secondary outcome measures included tolerability of each fixed combination. Baseline and follow-up visit evaluations included medical and ophthalmic history and a complete ophthalmic examination. Study drug was initiated after examination and randomization. Patients were asked about the adverse events and compliance, and the response were recorded. We have the results as mean IOP reduction percentage from baseline was 26% and 44% at 2 weeks, 26% and 45% at 1 month, 27% and 46% at 2 months, and 28% and 46% at 3 months with brinzolamide timolol and dorzolamide timolol respectively. Better tolerability and compliance without any adverse event was seen in 83.72% in brinzolamide timolol group and in 32.55% in dorzolamide timolol group. Tolerability of brinzolamide timolol and dorzolamide timolol with reference is given here. No adverse event in 14 patients in dorzolamide group, ocular discomfort in 10, ocular pain in 10, and blood vision was seen in 9 patients in dorzolamide group. Whereas no adverse event was there in 36 patients in BT group, ocular discomfort in 5, pain in 2, but no blurring of vision. According to ocular hypertension treatment study and collaborative initial glaucoma treatment study, more than 50% patients require more than one drug to reach target IOP. Reducing the amount of drops by including more than one medication is in fixed combination will reduce side effect and increase the compliance. Although tolerability is identified as a barrier to compliance, issue of efficacy needs to be carefully investigated. The purpose of our study was to compare the IOP lowering effect of both the drugs and with patients as primary outcome with patients' tolerability as secondary outcome. In our study, we found that both BT and DT significantly reduced IOP at study visits, but there were lower mean IOPs from dorzolamide group than brinzolamide group at all the study visits, significantly at 2 weeks. Manti et al. And Holo et al. Also compared BT and DT, but they only compared the efficacy, not tolerability. Regarding the tolerability of drug, beta blockers component of 2-carbonic anhydrase are similar, so any dissimilarity is due to the pH. DT has an acidic pH and BT has physiological pH. The present study shows that BT and DT provide effective lowering in IOP. Both fixed combination provide effective IOP lowering, but tolerability was bettered with brinzolamide group. And DT is more appropriate therapeutic choice for IOP lowering than BT for patients in need of more than one eye drop. Thank you.
How was your IOP measured?
I'm 80.
That's not mentioned.
Oh.
That's an important point.
We did in OPD, so we just did it with 80, all the patients.
That's okay. And any specific reason to rule out diabetic retinopathy in these patients? Like that was one of your criteria.
Yes, ma'am. Actually, we did not want any other ocular disease to interfere with the this outcome of the IOP measurement.
So your outcome was only IOP, right?
Yes, ma'am.
How does a mild NPDR affect IOP? Does it?
You have mentioned in the inclusion criteria that you have included patients who were not achieving target IOP with 1 or 2 drugs.
Yes, sir, other than these two drugs.
Other than these two. So, what was the initial first line choice of your treatment in glaucoma patients?
So, initial, as we have OPD patients, we started with timolol.
So, okay, your first line choice was timolol.
Yes, sir.
And then what was your second line?
So, second line was latanoprost.
Okay. Now, if these are not controlled with these two, now you have added brinzolamide and timolol.
Yes, sir.
Okay.
Those two drugs were used separately. One and not controlled on timolol. We stopped that and started with latanoprost.
So you stopped timolol.
Yes, sir. Only one drug was used at a time.
then latanoprost,
Yes, sir.
and then you started this combination.
Yes, sir.
How long do you wait to assess that the effect of one drug has gone off?
Ma'am,
It might be there in the body, right? In the blood. What's the washout time?
ma'am,
In
we
other words.
included 1 month was the period we used.
Sorry?
1 month.
1 month, you waited for one
Yes.
month and then you assessed.
Yes, ma'am.
So are you comfortable for back-to-back presentations or?
Okay, I'll do.
Yeah, we can go ahead
Okay.
with this next one.
Yes, ma'am. दूसरा वाला चला। Morning, one and all. We'll discuss about prevalence of primary angle closure disease, assessment with Van Herrick test, gonioscopy, and ASOCT. There are two major forms of glaucoma, open angle glaucoma, angle closure glaucoma. The high prevalence of occludable angles and primary angle closure glaucoma in people of East Asian descent suggests that all the adult attending OPD for an ophthalmological assessment must have an angle assessment. Gonioscopy is the gold standard using Schoffer system. Grading system by Van Herrick's use 4-point grading system, non-invasive alternative to gonioscopy. Anterior segment OCT is based on low coherence interferometry with a superluminescent diode having a wavelength of 1310 nanometer, allows a deeper penetration and cross-sectional imaging of the anterior chamber. The study was an analytical cross-section study performed over a period of 6 months in tertiary eye hospital. A total of 200 eyes of 100 random patients who were presented to OPD were included. Consecutive patients coming to OPD, aged between 40 to 80 years were included of either gender, having spherical refraction values between -3 to +3 diopter. Exclusion criteria was patient less than 40 years and more than 80 years, having history, any patient having history of prior laser or intraocular surgery, history of prior ocular trauma, mature or hypermature cataract, with severe corneal pathology which interferes with gonioscopy, dilated pupil due to any cause, or refractive error more than 3 diopter. We have the results as our sample population we distributed, left eye 100 and right eye 100, male was 60 and female 40 studied. Angle status with Van Herrick was found, 20 eyes were having closed angle while 180 having open angle. With gonioscopy we found 8 eyes having closed angle while 192 had open angle. With ASOCT we found 7 eyes having closed angle while 193 had open angle. Comparison of Van Herrick with gonioscopy, out of the 20 closed angle, we found 8 having closed angle on gonioscopy and 12 having open angle. While out of 180 open angle in Van Herrick, 180 all having open angle on gonioscopy. This gives the sensitivity of 100%, specificity of 93.75%, positive predictive value of 40% and negative predictive values of 100%, giving the diagnostic accuracy of 94%. Comparison of ASOCT and gonioscopy, out of the 7 close angle, we found 4 were having close angle on gonioscopy and 3 were having open angle. While out of 193 having open angle on ASOCT, we found 4 were having close angle on gonio, while 189 were found having open angle. This gives the sensitivity of 50%, specificity of 98.4%, positive predictive value of 57.1%, negative predictive value of 97.9%, and diagnostic accuracy of 96.5%. Comparison of Van Herrick and ASOCT, out of 20 close angle, we found 5 were having open angle, close angle on ASOCT and open angle on 15. Out of 180 having open angle on Van Herrick, 2 were having close angle on ASOCT and 178 has open angle. Gonioscopy is considered the gold standard for assessment of angle status. Sensitivity and specificity values of Van Herrick with gonioscopy as reference was found 100% and 93.75%, thus vindicating its value as a good screening test. High specificity value of 98.4% indicates that ASOCT could possibly be used as a confirmatory and diagnostic test to detect angle closure. However, screening potential of ASOCT was not proven due to low sensitivity. Angle closure glaucoma is a sight-threatening condition that can result in profound visual loss. In the early stages and in the predisposed eyes, the disease is curable now by non-invasive laser iridotomy. The prevalence of angle closure varies in different populations, thus it is very important to detect the angle closure as soon as possible. The Van Herrick method, because of its high sensitivity and high negative predictive value, can be used as a screening tool in detecting angle closure. ASOCT, on the other hand, having a high specificity, can be used to confirm angle closure. At present, gonioscopy is mandatory tool in the evaluation of anterior chamber angle assessment, and none of the above investigations can replace it. Thank you.
What do you understand by the term sensitivity and specificity?
Ma'am, sensitivity is to detect how many patients are having glaucoma, and specificity is to for how many patients we detected, as any test has sensitivity and specificity. Sensitivity is used as a screening tool to detect, and on an overall basis, how many patients can be considered as a glaucomatous patient. And specificity is to detect amongst those if anyone is falsely positive or falsely negative.
Still, sensitivity is an indicator of true negatives.
There's a formula, do you know that? Basically, you are going beating around the bush. Madam wants to know the formula and you are beating around the bush. Okay, what is the take-home message you want to give?
Sir, ultimately we should do gonioscopy in all the glaucoma.
We already
patients.
know that.
We just compared the three of the measures, as one can say that ASOCT is more advanced, so we can go for that, or Van Herrick's method is there, so for screening.
Van Herrick's, everyone does it. Is OCT, why it is not so popular? Because it is very costly.
That is true.
And gonioscopy is a cheaper option, is the gold standard.
Yes.
So, what is the relevance? Clinical relevance.
So
What is
that-
new?
So I just studied so that when we are, as residents, when we are doing the study, or when the residents are doing the study, they can either do Van Herrick, or if they are not going for gonioscopy in all the patients, they should be doing gonioscopy. in
All the
patients.
residents must learn gonioscopy. That you can't avoid gonioscopy at any cost. You know, our teachers, if they hear this, they will be, what you say, aghast. Every resident must learn gonioscopy. Okay, another important thing, what was the parameter used on anterior segment OCT for determining the angle closure? There are many parameters when you do anterior segment OCT. So what were the parameters used?
Sir,
There are certain specific parameters when you are doing anterior segment OCT.
sir, I know the segments. This is anterior chamber, anterior segment, that was.
No, there are certain
Parameters.
parameters. How do you determine on anterior segment OCT that this is angle closure or this is angle open?
So by measuring the angle with the angle of the.
What angle? There are specific terms. It's not
Study
simple.
was not done by you,
ASOCT was done by the technician.
so you did not take the trouble to go and actually sit there and see how.
I saw.
You should learn.
Yes,
no?
ma'am.
What did he? There are a lot of tools.
Who are checking the patient then?
The patients I was checking.
No, what madam is asking, the study was done by you or somebody else?
So
Who was your guide? You were doing it on based on just optometrist results you were accepting
oh
it?
no, the VS in our OPD.
So the optometrist decides on anterior segment OCT that this is open.
Who is the expertise, optometrist or yourself? Of course.
Supposed to be. It's supposed to be.
Please go and read what are the different parameters. It's not as simple as saying this is open, this is closed.
Will you go back and learn the tools? Okay, in ASOCT.
Okay, thank you.
Thank you.
After Dr. Nilesh, who is the next presenter? Who is in the queue?
Dr. Priya is here.
Dr. Priya Sharma.
Please be ready.
Okay, Dr. Nilesh, start.
Thank you so much, sir. So good morning to all the judges and everyone in the audience. I would like to thank AIO's scientific committee for providing me this opportunity. I'm Dr. Nilesh Kumar, and I'm here to present my work on validation of a smartphone-based gonio imaging technique, direct imaging of gonio mirror by a smartphone.
All the presenters are requested to wait for group photo.
These are my financial disclosures. I hold the patent and the commercial rights of the device used, and we have taken utmost precaution that my bias doesn't affect the outcome. Glaucoma, as we all know, is the leading cause of irreversible blindness worldwide and has much more higher incidence of angle closure glaucoma compared to the world in India. The only way to differentiate open and closed angle is with gonioscopy. But it is not performed in all the patients. In fact, only half of the patients visiting glaucoma clinic in US get a gonioscopy done at baseline. 80% of the junior residents are not confident doing it, while 25% of the practicing ophthalmologists who perform it are not happy with their skill. The major roadblocks include the enigma of the skill itself, the dependency on slit lamp, the lack of quality trainers, and the time it requires in busy OPD. And we don't have feasible options that can reliably replace gonioscopy. The Van Herrick technique, the AIOCT, the UBM, or even the gonio pen that has come out, it is not very easy to perform. So our research question was, can we find a reliable, rapid, and frugal method to classify open and closed angle glaucoma in all the situations? So we devised a smartphone-based gonioimaging technique based on the principle of indirect gonioscopy. The published article is the pilot study to validate the underlying principle which formed the basis of the present study. This technique was then refined to innovate the smartphone-based gonioimaging device, which is world's first and till now only of its kind, which we call DIX Pro. The aim of the current study is to validate the images obtained using DIX Pro by correlating them with the gold standard slit lamp gonioscopy. So it was a prospective single-center, single-mask validation studies conducted from April 2019 to March 2020. Sample size was calculated to be 222 images based on the previous pilot study. With the gradable image acquisition of 80%, we required 278 images. A single physician did the slit lamp gonioscopy to grade the angle. Another masked physician performed the gonio imaging using DIX Pro. 4-mirror gonio lens was used for both the procedures, and 1+6 smartphone was used for obtaining the images. So this is how the device is set up for use. We place the gonio lens in the adapter, which by design aligns centrally with the optics of the smartphone holding segment, where the smartphone is snap fit. So we screw the gonio lens, we snap the camera, and a normal camera app is used. The lens with the holder is applied in normal fashion under topical anesthesia, and the patient is asked to look straight. When the patient is looking straight, the smartphone segment aligns with the center of the lens adapter, and you just click using the camera flash. So it is a diffuse flash-based imaging technique. So this is, with a single click, you can obtain 360-degree images if you are using a 4-mirror or 6-mirror gonio lens. The quality of the image was classified into gradable and non-gradable quality based on the criteria as adapted by Azad et al. For their ROP study, and a Schaffer's classification was used to classify open and closed angle. The physician performing the gonioscopy graded the gonio images on a later date. It was completely masked, all the identification was removed, and another grader also graded the images, so we can have a inter-observer and intra-observer correlation. Both the graders were having no financial interest in the device, and IBM Spaces version 23 was used to calculate the Cohen's kappa coefficient. So sequential images were obtained. For sample size of 250, we attained 280 images. Out of that, 250 were of gradable quality. 55% of the patient had open angle and 44% had closed angle. The inter-observer agreement was 0.65, which signifies a substantial agreement, and the intra-observer agreement was 0.82, that was also a clinically substantial agreement, and even we targeted the trabecular meshwork pigmentation, and 91.6% of trabecular meshwork pigmentation was correlating. So these are some sample images that we obtained during our study. Angle recession with hyphema, iridodialysis cleft, a glimpse of the disc and mid-dilated pupil, peripheral anterior synechiae, Sampolsky line, plateau iris configuration, silicon oil, that is the inverse hypopyon, and synechias. So gonioscopy is an essential component of glaucoma diagnosis and determines the line of management. The current study provides a cost-effective, frugal, innovative, slit lamp independent method to classify open or closed angle that can be deployed on grassroots level. It provides a clear gradable image in 80% of the photographs obtained with sufficient details to classify the angles. Our study reveals the prevalence rate of 55% of open and 45% of the closed angle, which is what the Indian population has. So thank you for the opportunity. The study limitation is that it is a flash-based diffuse illumination and not a minimal illumination technique. So thank you.
First of all, you crossed the time limit.
Oh, sorry, sir.
Secondly, as far as I know that the presentation which you are presenting here should not be published anywhere before presentation over
Yeah,
there.
so this has not been published, sir.
Just show them.
The underlying principle, it was not on the device, it was just a gonio lens and a smartphone.
The same thing.
No, sir, this
What
device,
is the difference between your
the
article
dev-
in the journal and what you are presenting?
yeah, it was a two-hand technique, sir, where there was no alignment.
In what was in
Yes,
the
sir.
journal and what you are
Yes,
presenting?
sir.
What is the difference?
In the journal, we were just having a 4-mirror gonio lens and a phone, and we were just trying to center the image. There was no optical magnification involved because it was just a phone and gonio
Over
lens.
here also
In
you
the
are doing the same
no, sir.
thing.
In the device, there is an macro lens that is involved, so we have more clear image. It is a 2x magnified, optically magnified image. The centration is well. It is a closed environment, so no external light is coming in. So there is, it is free from all the reflections that is from the outer source. So
There are minor differences.
yes, the minus.
Basic concept is same.
Yeah. The basic underlying principle was the same, sir.
Second, the next point is, in your video you showed that you use the flash.
Yes, sir.
Now, as far as I know, when we
Yes, sir.
do gonioscopy, there are certain requirements to be followed.
Yes, sir.
One of them is regarding illumination.
Yes, sir.
Now, if you are using a flash, that will open up most of the angles. That will not help us to differentiate angle closure and open angles in certain cases. That
Yes,
is
sir.
why we are doing gonioscopy
Yes,
to
sir.
differentiate. Not the clear-cut cases, angle recession and silicone oil, or
Yes, sir.
these things are very clear-cut. Gonioscopy is very important to differentiate in some cases where you think it may be an angle closure or open angle because
Yes, sir.
illumination broadens up the angle and you are missing angle closure. So we are
Yes, sir.
we'll,
So,
we'll be missing this will give us higher open angles than
Yes, sir.
angle closure.
So, sir, can I, this is the most, this device has been in use for last 3 years, and this is the most common question. The first question that I get this is diffuse illumination, how it is going to work. So, the pupil lag time, once we shine the light on pupil, the reaction starts at 300 milliseconds. There is one third second lag between the in the pupillary action, and the flash illumination and the image, the duration that it takes is 1/100th of the second. So even before the pupil start constricting, this is done. And we have a video proof. We have devised a slow motion videography where we shine the torch, we shine the flashlight, we switch it on, and in the slow motion we can see the pupil constricting and the angle opening up. So even before the pupil reaction starts, we click the image. That is the practical aspect that, but theoretically, yes, we are working on it for the next devices where we can have an external light source where it can be controlled and it can be minimal. But
You are saying a frugal-based smartphone to avoid gonioscopy.
no, sir, not to avoid gonioscopy. This is just to do a grassroots level screening
Now,
to
why
catch.
why do you want to do this? Because you don't want to do gonioscopy.
No, sir. This is when we go in camp, we don't have a slit lamp, and we see the patient, and then we bring the patient based on Von Herrick method or by shining temporal light and seeing the crescent. So we wanted to devise a method where we really know if it is a closed angle, a
So
open
you
angle,
want to
and
do
bring the
this in
closed
the
angle.
screening camp in villages.
Yes, sir. We are using it. A thesis has already been accepted by DNB for the same, sir.
Gonioscopy is much more simpler than this. This is a very difficult technique.
So this is just to bring the patient, so we can reduce the burden of closed angle glaucoma. We can perform a YAG PI, sir.
Okay.
Yeah. Thank you, sir.
I have
Thank
one
you so
question,
much.
but we have less time.
Sure. Thank you, sir.
You can start. And we have started the hall a little late, so sorry. There are presenters. Dr. Priya? Yes, sir. Yeah. You are non-ratified member, so the marks are not to be given, right?
We are not supposed to
Dr. Mridula Ranjan?
No, she can present the papers. Eh?
Yes.
I just told her. Dr. Mridula Ranjan?
But I have membership number also.
It's
No,
not
that is not
ratified.
ratified.
It will be
It will be
ratified
not
in
yet.
this conference program.
Dr. Amina? You be ready there. After that, Dr. Shweta Singh? Yeah. And then one more. That is Dr. Rupa Gupta. Yeah, please. Please go ahead.
Good afternoon everyone, I am Dr. Priya Sharma from KGMU Lucknow. I am going to present on evaluation of serum, tumor necrosis factor alpha and vascular endothelial growth factor A in primary open angle glaucoma cases. Glaucoma is one of the leading cause of irreversible blindness worldwide. It causes progressive damage to retinal ganglion cell. Cytokines-mediated immune and inflammatory response play an important role in the process of glaucomatous optic atrophy. TNF-alpha is a pro-inflammatory and neuroprotective cytokine. Immunological and physiological processes associated with retinal ischemia, neuronal damage, and tissue regeneration. Vascular endothelial growth factor is a 45 kilodalton glycoprotein. It is secreted by endothelial cells, smooth cells, macrophages, and tumor cells. In open-angle glaucoma patient, vascular autoregulation abnormality has been observed, which may be suggestive of hypoxic response, leading to increase in vascular endothelial growth factor. Aim and objective evaluation of serum tumor necrosis factor alpha and VEGF-A in primary open glaucoma cases. It was done in Department of Ophthalmology in collaboration with Department of Biochemistry in a tertiary care hospital. Ethical approval was taken by the Institutional Ethical Committee. Study duration was 1 year. It was an observational case control study with sample size of 44 with 22 cases and 22 controls. Inclusion criteria was patient giving voluntary written informed consent, patients of POAG in between 40 to 65 years and healthy aged matched controls. Exclusion, patient with any ocular or systemic disease which can alter retinal vasculature, patients having systemic inflammatory conditions like diabetic mellitus, hypertension, arthropathies, end-stage renal diseases, tuberculosis, malignancies. Any pregnant and lactating females and patient who participated in another study in less than 6 months. Case selection, patients who attended glaucoma clinic and the outpatient department in Department of Ophthalmology, a detailed history and ocular examination was done. Around 3 to 4 ml of blood was collected from cases and control and stored in -20 degree after centrifugation in Department of Biochemistry, and the ELISA technique was employed for measurement of serum levels of TNF-alpha and VEGF-A. Majority of the cases enrolled in the study were males and rest females, and among controls there were more of males. And the difference between gender among cases and control was not statistically significant. Age of the subject enrolled in the study was from 40 to 65 years with a mean age of 54.77, and the mean age of control was 48.09, and this was comparable. Habitat of cases and controls were found to be comparable. This table is showing comparison between the IOP, contrast sensitivity, corneal thickness, OCT, RNFL among cases and control. Corneal thickness and OCT RNFL thickness among controls were found to be significantly higher as compared to cases. Mean serum TNF-alpha was found to be significantly higher in cases compared to control, and mean VEGF-A value was slightly greater in cases and control, but this comparison was not found to be statistically significant. Mean serum alpha, TNF-alpha found to be greater in severe cases compared to mild to moderate, but this relation was found to be statistically insignificant. And mean VEGF-A was also increased in cases of severe cases, but the comparison was statistically insignificant. Conclusion, there were increased levels of serum TNF-alpha and VEGF-A in patients of POAG as compared to healthy controls, which indicates high systemic level of these parameters are associated with POAG. These were increased in severe cases, but their association with the severity disease was found to be statistically insignificant. So there is some possibility of some involvement of these parameters in POAG. However, their role as biomarker could not be established, and this needs further investigation. Gunham et al. In 2011 conducted a study that a total 35 patients with POAG and 30 patients with senile cataract of matched age and gender were included in the study prospectively. A positive correlation was found between TNF-alpha and IL-6 in aqueous humor of POAG patient. Significant correlation was found between TNF-alpha and IL-6 levels and severity of visual field loss in moderate stage. In 2019, Pantolon A et al. Conducted a cross-sectional study of 87 eyes. The level of aqueous humor in HF in patients with POAG was significantly higher than that in patients with cataract. Thank you.
Thank you. Thank you so much. Okay, you can start.
You can start.
Okay. Good morning, everyone. I'm Dr. Amina Clark from RIO Sitapur, and I'll be presenting my paper on the role of pentacam in studying the effects of laser peripheral iridotomy on the anterior chamber in synechial angle closure. I have nil financial interest. So as we know that glaucoma is the leading cause of irreversible blindness worldwide, and primary angle closure glaucoma is an aggressive and visually destructive disease with estimations that it blinds 5 times more people than primary open angle glaucoma. Unfortunately, the predictive value of gonioscopy is relatively poor in determining which susceptible eyes will develop overt angle closure even when experienced clinicians perform gonioscopy. Hence, we need devices that can objectively measure these parameters. So Pentacam is one such device that is a comprehensive anterior chamber analyzer, and it has a 3-dimensional rotating Schempfler camera that non-invasively acquires cross-sectional images to quantify the anterior segment of the eye. So the present study was conducted to compare the effects of LPI in synechial angle closure in its 2 stages, that is the primary angle closure PAC and primary angle closure glaucoma, on the anatomical and clinical parameters. The quantitative changes in the parameters were to be assessed by the changes in the anterior chamber depth, both central anterior chamber depth CACD and the peripheral anterior chamber depth PACD, and the anterior chamber volume as measured by Pentacam. The clinical changes to be assessed by the changes in the intraocular pressure, and the anatomical parameters by the changes in the gonioscopy pre-LPI and post-LPI as per the Schaffer's grade. So we included all the patients presenting in the glaucoma department and divided them into 2 groups, Group A PAC and Group B PACG. PAC was defined when there was more than 270 degrees of iridotrabecular contract and raised intraocular pressure and or the presence of peripheral anterior synechiae. And PACG was the presence of PAC with glaucomatous optic neuropathy and corresponding visual field effects. The patients were studied for 1 year. It was a prospective observational study, and the sample size was 160 eyes, 80 each from PAC and PACG respectively. The patient underwent an in-depth ocular examination including visual acuity slit lamp, IOP by Goldman's applanation tonometer, gonioscopy with a Sussman 4-mirror lens, and all the eligible eyes underwent anterior segment imaging using Pentacam before LPI and at 1 week and 1 month follow-up. So we included patients diagnosed with PAC or PACG with age more than 40 years and willing to sign the consent form and comply with the post-procedure follow-up schedule, and the patients unwilling to participate in the study, secondary glaucomas and any other ocular abnormality other than glaucoma, including history of cataract surgery or open angle glaucomas, were excluded from the study. So we observed that from a total of 160 eyes, 107 were females and 53 were males, and majority of the patients that underwent LPI in both the eyes. So these are the results showing that in the PAC group, when we compared the pre-LPI and the week 1 findings, the anterior chamber angle improved, the Schaffer's grade improved in all the 4 angles with p-values less than 0.05. This finding was seen at both 1 week and 1 month. Now in the PACG group, similar findings were noted that the Schaffer's grade improved, but the improvement was less as compared to the PAC group due to the presence of synechiae. This is the image of the Oculus Pentacam used in a study. The 25 image acquisition protocol was used, which automatically calculates the anterior chamber volume and the central anterior chamber depth, and we calculated the peripheral anterior chamber depth in a 9mm circle in relation to the center of the pupil at 12 o'clock, 3 o'clock, 6 o'clock and 9 o'clock. So the values, this is a tabular form showing the values, which shows that in the PAC group, both at 1 week and 1 month, all the values CACD and the peripheral anterior chamber depth and the anterior chamber volume improved dramatically with p-values less than 0.05, which was significant. But while in the PACG group, the IOP reduction was significant, but the PACD at 9 o'clock, that was only significant. Other values improved, but it was not significant. So as we know that the number of people affected worldwide with glaucoma by 2010 was 40%, mainly in Asia, with more than 75% being angle closure patients. And to effectively prevent PACG by using PI, it is necessary to identify people with narrow angles. So we found out that laser peripheral iridotomy causes significant changes in the indices of anterior chamber, which can now be documented objectively with the help of Pentacam. And we studied only eyes with synechial angle closure and found similar results as previous studies, that the improvement in the AC parameters was more in PAC as compared to PACG, and therefore we conclude that Pentacam is an excellent non-invasive tool for measuring and quantifying changes in anterior chamber following laser PI, and hopefully in the light of observations made in our study and previous studies, Pentacam may holistically used in glaucoma diagnostics for primarily. And in the best of our knowledge, there has been no other study conducted which assesses the role of Pentacam in evaluating the effects of LPI. These are my references. Thank you.
Thank you. I think Mrudula is absent. Mrudula Ranjan is absent. Correct? So Abhina is done. Shweta Singh is there.
Yes, sir, yes, sir.
And you go there. You will be the last presenter. Please.
Good morning, everyone. I am Dr. Shweta from KGMU, Lucknow. I am here to present my free paper on topic platelets parameters and coagulation profile in primary open-angle glaucoma patients. There are various pathomechanisms related to the causation and the progression of the glaucomatous optic neuropathy. Most popular theory is the vasculogenic theory, which is related to the altered blood parameters and leads to the hypercoagulable state in glaucoma patients. Recent literature also suggests that there is association of the altered platelet parameter in POG patients. This is the first study which is done in the Indian population and assesses the coagulation profile along the platelet parameters. Previously, none of the study done in the coagulation profile. Aim of the study was to study the platelet parameters and coagulation profile in patients with POAG. Primary objectives are to compare all the platelet parameters among the POG patients and controls. And secondary objectives are to study the association of these factors with the severity of the POAG patients. Study was prospective cross-sectional analytical study, which is done in the period of 1.5 years. 40 cases and 40 controls included in the study. Descriptive analysis was done for the demographic details, and student independent t-test applied to compare the platelet parameters between the cases and controls. ANOVA test used to assess all the parameters in patients on the basis of the severity. A p-value less than 0.5 would be considered statistically significant. There are inclusion and exclusion criteria for the cases. Consenting POG patient included, age 40 to 60 years are taken, cooperative for the visual field examination. Exclusion criteria included pregnant females, visually significant cataract, visual acuity less than 6/60, ocular trauma, retinal diseases, other optic nerve disorders are excluded. Intracranial lesions, hematological diseases, coronary artery diseases, cardiovascular accident, and hepatic renal diseases, and patients on antiplatelet and anticoagulant therapy are excluded. And these are the exclusion and inclusion criteria for the controls. These are the results of the MAI study, and no significant difference found in the demographic details of the study subjects. All these platelet parameters we have studied and compared between the primary open-angle glaucoma group and control group, and found that the platelet count significantly decreases in the primary open-angle glaucoma patients, and mean platelet volume and platelet aggregation significantly increases in the POAG patients. In coagulation profile, we found that the fibrinogen and D-dimer significantly increases in the POAG group compared to the control groups. Then we compared platelet parameters between the mild and severe group of POAG patients, because both groups had approximately equal number of the study subjects, and found that the platelet crit and platelet count more in the severe group compared to the mild group. Then we compared the platelet parameters between the mild and severe group of the coagulation profile compared between the mild and severe group of the POAG patients, but no significant difference found in the coagulation profile in mild and severe group. Nijima et al. Found that the platelet aggregation increases in the glaucoma patient. Yima et al. Also found that the platelet activation involved in the pathomechanism of the POAG, and other authors also suggest that the hypercoagulable state found in the glaucoma patients. In our study, we found that the low platelet count, high mean platelet volume, high platelet aggregation, fibrinogen and D-dimer levels are higher, and all deranged parameters results hypercoagulable state in the primary open-angle glaucoma patients, which affect the microvascular circulation and contribute to the development of the glaucomatous optic neuropathy. Limitation of the R study are the smaller sample size, age and gender-wise analysis of the parameters could not be done. Platelet and coagulation parameters may be vary with the ethnic and racial differences in the population. Thank you.
Thank you. Thank you for the presentation. You are the non-ratified member. Thank you. Now the last presenter, she is the competitive presenter from the session 1, and she is one of the finalists. We will have to assess her. Please start.
Good morning, everyone. My topic is factors affecting compliance to anti-glaucoma medications during COVID-19 pandemic and its effect on progression. I have no financial interest. Second wave of COVID-19 hit our country during the late of March 2021, which was much more devastating than the first wave. And in order to curb down the unprecedented spread of the virus, travel restrictions and mass quarantine were implemented throughout the country, which usually affect the treatment of chronic diseases like glaucoma. Even before COVID-19 pandemic, adherence to anti-glaucoma medication has been an issue, and the pandemic had led to worsening of the situation. So our study aims at finding the factors that affect the compliance of those anti-glaucoma medication during the wave of COVID-19 pandemic and progression of the disease due to it. It was an observational cross-sectional study conducted at Tertiary Care Hospital in the Cuttack district of Odisha from December 2021 to June of 2022, including patients of primary open-angle glaucoma who are on anti-glaucoma drugs more than 18 years of age, excluding newly diagnosed cases of glaucoma, secondary glaucoma, primary angle closure glaucoma, history of glaucoma surgery, patients who were non-compliant before second wave of COVID. Patients were examined in two parts. First part consists of a questionnaire containing demographic and clinical data and barriers for medication adherence during the pandemic. Second part consists of examination, that is BCVA using Snellen's chart, IOP we using Goldman appellation tonometry, visual fields by automated perimetry, and RNFL thickness by OCT. Total number of patients examined were 220 eyes of 220 patients. Out of 220 patients, 130 were found to be non-compliant to anti-glaucoma medications, that is 59.09%. 143 patients were from 60 years of age group, 132 were males. 58% belonged to rural area, 63% had to travel more than 50 kilometers to the hospital, 68% belonged to low socioeconomic status, and 78% were using more than 2 anti-glaucoma medications. The most common barrier for compliance to medication during COVID-19 in our study was financial difficulty, followed by longer distance to hospital, unavailability of the transport, non-availability of the medication, and some other factors. Statistical analysis was done using SPSS software, and paired sample t-test was used to compare the best corrected visual acuity, intraocular pressure, RNFL thickness, and VFI between comparing two groups, that is pre-COVID second wave and post-second wave of COVID, and the mean difference between two groups was found to be statistically significant with a p-value of less than 0.001. So our study showed 59.09 patients as non-compliant to anti-glaucoma medication, whereas study by Ekan et al. Saw a low non-compliance rate of 28.4%, and Rijon et al. Showed a high non-compliance rate of 80.5%, and Shubhadra et al. Showed a similar non-compliance rate of 57.3%. Main reason for non-compliance to medication in our studies was financial difficulties, whereas studies by Shubhadra G et al., Somi et al., Rijon et al. Showed non-availability of the medication as the main barrier. 80.76% patients in our study had raised IOP, 24.61 has decreased RNFL thickness, and 12.30% patient had reduced VFI than pre-COVID time, which is an effect of non-compliance, whereas the study by Somi et al. Showed 81.25% patients with raised IOP and 78.13 patients with reduced VFI. So to conclude, COVID-19 pandemic has caused a statistically significant increase in the rate of non-compliance to glaucoma medication, principally resulting from lack of financial resources in our setup. This non-compliance has resulted in statistically significant increase in intraocular pressure, decrease in BCVA, RNFL thickness, and VFI compared with pre-pandemic situation among patients presenting to our facility. So we recommend teleophthalmology to be the future to meet the need of glaucoma patients during pandemic. This is the questionnaire. Thank you.
Do you think your title of your study is a little misleading because it's not pre-COVID and post-COVID, it's the second wave that you've taken into account, right? And people were more handicapped during the first wave.
Yes,
right?
actually there were studies where many studies are there on the first wave, so we thought
So your
we'll
topic
take.
should not have been COVID-19. It could have been the second wave of COVID.
Yeah, if I okay, ma'am.
For COVID
got it.
patients, steroids were used quite vigorously in
Yes,
the treatment of COVID patients. So has that affected intraocular eyes
Sir,
because of steroids? What is your observation?
sir, it actually increased the intraocular pressure, but we have taken all the primary open-angle glaucoma patients, sir. Very few of them were affected by COVID-19 only. Rest of them were only POAG patients, sir.
COAG doesn't protect you from getting COVID. So that should have been your excluding criteria probably.
Okay,
We should have looked that into.
okay, ma'am.
Okay, anything else? I think, thank you so much. It was a wonderful presentation. All the presenters have done wonderful job. Congratulations to them. We'll have one group photograph. I'm very sorry for the next team because we started late. It was not possible to start the hall on time.
5 minutes delay.
Group photo, you can come. All presenters.
Actually, the mark sheets were not available, so we did not have papers to write the marks.
will come whether the patients are examined by male doctors or female doctors.